Hello, and welcome back to our 8th episode. And this month we're changing things up. I'm joined by my lovely colleague Letitia. Hi Letitia.
Hello, Megan.
Hiya. Could you introduce yourself briefly for our lovely listeners?
Hello, thank you for that. I'm Letitia, but you can say it's Leticia, but you can say Letitia. So I'm a knowledge and evidence specialist. So a bit like other colleagues you have already seen on the podcast, Veronica. So my specificity is mental health. So I work a lot with our mental health colleagues, and I do evidence searching, and I support them in their project and in research as well.
Absolutely. So that brings us to our theme this month. It is Mental Health Month. So we are going to be talking about that today. And we do have some exciting news to share at the end of the podcast about the year of reading. But before we go over to that, I'm going to pass back over to Letitia to introduce our guest for the month.
Hello, our guest from us, and I'm really pleased to see him today, is Adrian. So Adrian Hayes is consultant psychotherapist. Is using both psychiatry and psychotherapy, background in psychology. You have both this background in your work. And you also working in mental health research. So you're one of the leading in mental health research in our trust. And you are supporting, conducting research, and you're organizing also bigger research, supporting in the trust. And your area of research is complex emotional needs.
Hello, thank you. That's a nice introduction.
So yeah, please introduce yourself and tell us in your own words a little bit about your role, Adrian.
Yeah, I will do, because it's a strange one. So yeah, I'm Adrian. I'm consultant medical psychotherapist. So that means I've got a background in medicine and then psychiatry and then psychotherapy. So I sort of sit in between the medics and psychologists. The main reason my job exists is to make sure the trainee psychiatrists get some experience of psychotherapy, which is always helpful. And I do quite a bit of training and supervising and sort of reflective groups. And I tend to sort of help out patients or teams who are a bit stuck. It's a bit of a troubleshooter. But as Leticia says, I work in complex emotional needs is the clinical area. And then I've got a bit of time for research as well. So it's quite a fun job. Never a dull day.
And it sounds like it's different every day as
It is
well.
different
It's
every
not
day.
going to be the same.
And in a different place. No one ever really knows where I am, which is actually the biggest benefit.
Hard man to pin down.
But I go around trying to make myself useful.
You certainly seem to be doing a very good job at it.
Well, we are here for a specific reason. So can you tell us about that exciting research project coming out in Somerset that we're launching?
Yeah, thank you. So there's a few things to talk about, but I'll start with this big one. So this is exciting. So this is something called the Mental Health Research Group, funded by NIHR. They funded a few around the country, and the idea of the funding was for an academic institution which doesn't do very much mental health research in a geographical area that doesn't get much benefit from mental health research. And they team up with other institutions that do have that experience. And they also team up with services locally. So Plymouth Uni were the main applicants. They've teamed up with SLAM in London and Exeter. And they've teamed up with us in Somerset Trust and the other trusts around Devon, Cornwall and Plymouth. And it's a really big grant of several £1 million. It's going to last 5 years, and they're doing a few things. So I'll tell you a bit about what they're doing. So they're trying to essentially bring more mental health research in, and bring in the type of research that really benefits people who are there, who live there, and who need mental health services, especially people who aren't getting it at the minute. So it's sort of looking at the gaps, who's not getting something. And we're calling it a sort of research partnerships. It's quite unusual. Usually a university come up with a project, and they come to us as a trust and say, can we do this project here? And we think about it and generally say yes, but we don't then get much say in what they're doing or how they're doing it or what happens next. So this one's a bit different. So this is a partnership where the university comes to us and we work together with them. So they wanted us as a trust to come up with the questions, to think about what do we not know about our service that we would like to know, who we're seeing, how we're doing, who are we not seeing, where do people go, how much does it all cost. So we come up with the questions we want answering. Then the university helps us to answer them, and they've got some quite complicated data linkage stuff they're doing, which I won't talk too much about, obviously, for time, not because I don't understand it, partly. So they'll help us answer those questions, and then we'll then think, what do we want to do about it, and come up with some innovations and some projects, and then they'll help us evaluate those. So it's I've worked in research for quite a long time, and it's one of the best examples, I think, of working together and having research really help out your clinical work. Normally, it's really hard to do that because it takes so long to do the research, and it's really hard to match up. But this time, that's what we're doing. So it's just started in April. So we're in the very early stages, but we've got a few things we're doing in the first 18 months to sort of prove ourselves. And then, all being well, we'll carry on for the 5 years.
I know you were very excited for this one when we previously spoke about it. It was...
But I am.
Well, still are, yes. The excitement has carried on.
Yeah.
It's a very interesting way to see research, very much almost like a co-production between the trust and the actual university. So
Yeah.
it's a very innovative, interesting way to approach this.
Yeah, it really is, and it's how I like to work, actually. So that's sort of my job, really, is to what I wanted my job to be, is part clinical and part research, and do the same thing. So use the research to help the people that I'm working with, and that's how I was trained, actually. If I could say something about, because I have to give the heads up for my first ever supervisor, so 25 years ago now, Professor Jenny Shaw, and she was a consultant forensic psychiatrist who did half clinical work and half research. And she also had 4 kids, and she was learning to play the piano, and she made her own coleslaw. So, she was a bit of a superwoman, but she really so it's my first job out of uni, and she drummed into me thinking about research projects. The first question is always, so what? How does it help me? How does it help the nurse on the ward? How does it help that patient? And if you can't answer that, stop right there. Don't bother. It's got to be useful to someone. So I've really taken that to heart, and Johnny retired last year. So I'm trying to carry on her legacy. Fill her shoes, exactly. It's so important, but it's not easy. Yeah, it's not easy to do the two.
And it sounds like it's a nice mix of, obviously, we've had universities approach us for research before we trust, but it sounds like this is a nice segue into that more, as Letitia said, co-production of the research is going to directly impact, we're going to have a direct say in where it's going and how it's affecting our patients. And
yeah, definitely. And and it's co-produced, so we're trying to incorporate all the different voices as well. So we've got the sort of senior people in the trust. We're also going to the people at the very front line, the frontline clinicians, the sort of clinical lead, the people who really know what's going on and what needs doing. We're doing lots of work with people with lived experience themselves of mental health problems. Their voice is very much in it. And also, mental health in Somerset is very, very closely networked with the voluntary sector. We've got the Open Mental Health Alliance. So all of those voices are part of it. So it's quite, it makes it hard. It's quite chaotic, and it's a bit messy, but it needs to be. I quite like messy.
So on that note, if people want to get more involved in mental health research, how can they go around sort of doing that within the trust?
Oh, well, that's a good question, because that's been what I've been doing for the past 2 years, actually. So I sort of made it my business to try and get mental health research going a bit in the trust and giving a lot of people their first experience of research, because we don't have a university in the area. And what I found is a lot of clinicians like the idea of research. A lot of them have had bad experiences in their training of finding it a bit above their head or a bit boring, a bit dry, or not thinking that they could do it. And so I'm here to sort of say that they can. So I do that in a few ways. So first of all, I run a monthly get together meeting for anyone interested in mental health research can come along. It's very informal. Leticia is always there and chips in. So we talk there about what projects we've got going and anything new that we're thinking about taking part in. So we get some good opinions from people. And we find out from the clinicians there who might have patients who are eligible for these studies. That's really helpful. So it helps with the recruitment. So we sort of host. So we haven't had that much homegrown research, mental health research in Somerset up until now. But what we have been doing is hosting these national projects, as I said at the start. So we've usually got about 10 of those going on. And we've got an amazing researcher, Ali Long. Big up to Ali, because she works tirelessly for us. She's done it for a long time. She sort of does all the work and runs around. But I've been matching up clinicians to help her out on various studies, find them a study that they're interested in or that matches their clinical area, and they can have a fun experience. The fun bit of research is meeting patients, telling them about a study, doing the consent, doing any questionnaires or measures, sometimes a blood test. And so that's the fun bit, I think, isn't it? The fun bit of research is not sitting at a laptop for 6 months,
Yeah.
We don't start there. We start with the fun bit, and then lots of people enjoy that and then take up a more formal role or carry on. And so we're building on that. And we've had loads of interest, loads of appetite. There's lots of sort of training people around who need a bit of experience of research, and then there's lots of clinicians who want to try it out and see for themselves, and they have a good time. They tell us, they tell us they enjoy it. It adds something extra to their work. It means they can offer something a bit different or a bit new to patients. They feel like they're sort of at the cutting edge of something. There's something innovative, and it's a nice network.
Yes.
I think there was another myth that I found, that people in research are a bit cutthroat and always trying to steal each other's ideas, and that does exist some places. It's not my experience. That's not how I work at all. So it's all share the wealth, isn't it? With us, I think we share ideas, we do it together, and we promote it all and allow whoever's done it to take the credit.
Yeah, I think it's also very supportive, because it could feel very daunting, and the fact that yes, there is multiple obstacles and there is difficulty, that it could be over loads of different things. It could be ethics, it could be legal, it could be money, or time is another one. And it's a supportive, and because it could take a long time to actually get published and do the research. So having the supportive environment is really important, and also sharing the information. So because when you are in the trust and you start research, you might not know who to ask or who to go to. So having someone in a network is good.
Yeah, totally agree, and lots of that. So most research stuff is best done in small groups, I think, because then you motivate each other. Because as a busy clinician, it is quite hard. Research never really quite gets to the top of your to-do list. There's always something more urgent. But if you keep up the momentum, and in a group that's a bit easier, you can really get somewhere with it. But it takes a bit of planning. And I agree with you, it's daunting. And if you start off thinking, I've got a research idea, I want to get started, where do I start? Let's apply for some money. Then that's sort of impossible to do on your own. And that's why that's not where we start here. We start with the experience and then build up how you get your own stuff off the ground, because that's really hard.
So is there like a link or an email if people are interested in joining the network that they can reach out to?
They can email me directly, Adrian.Hayes at Somerset. Yes, and I just invite them to the monthly meeting, and there is a mail out that comes after that as well with all the information for anyone who can't come. People dip in and out, and often I meet with people individually or as a group to see where they're up to, what they need, and then I sometimes put them in touch with someone else called Ralph Hammond,
Yeah.
Have you? I think you've.
We've met Ralph. He
Yeah.
hasn't been on the show yet.
Oh right,
but
not yet.
Not yet. There's a big yet.
Okay.
But
Get
yes,
on.
Veronica works quite closely with Ralph, doesn't she, as well?
Perfect. So I put people onto him who are sort of the next stage, who want to think about moving up, moving on, getting some money, or doing a course, or some formal training, that sort of thing. Ralph's a great person across the trust who sort of knows all of the different schemes. So I start them off, then Ralph takes them to the next step.
Perfect. If you don't mind, I'll pop the contact information below so people will be able to know who to reach out.
Very welcome.
And so we have talked about that massive project, mental health project. Is there another piece of research you would like to talk about?
Yes. I mean, always. So while I've been helping other people and getting other people's research going, and also been sort of busying myself with my own interest. So that's from the world of complex emotional needs or personality disorder, those sorts of terms that people have used in the past. So that's my sort of first love clinically. I really love working in this area. And the main interest I've got is in what I'm calling self-agency. So people with these difficulties, usually people who've gone through a lot of terrible things in the past, struggling with things like emotions and relationships and keeping themselves safe. And there isn't a sort of a medication or a set of skills or something you could just tell someone for how to change those things. It's much harder. It's much more sort of ingrained, and it's really hard to manage those sorts of difficulties. And in my experience, people sort of have to sort of find it in themselves. So they have to sort of think about what they normally do, and often that's something perhaps a bit impulsive or something a bit unhelpful for them, and they're not living the lives that they want to live in the way they want to. So they have to sort of find in themselves a way of not doing the usual thing and have a different option available and to put that into action. So that's really hard. And people have to have a lot of backup, a lot of support, a bit safe connection with someone like a clinician or sort of supportive group before they can even start that. So it's a bit involved. Something I see in therapy, people find in themselves. So if someone's doing well in recovering in therapy, it's not usually what I'm saying to them. I'm sitting with them while they figure it out themselves, if that makes sense. So I'm really interested to understand that a bit more, because it's not very well defined, it's not very well understood, it's not very well described. So I've kicked off a few different studies to try and learn a bit more about self-agency in complex emotional needs. So I've got a little group of people, clinicians and trainees, and a few people with lived experience as well, that we meet at regularly, come up with ideas. We've written a couple of things together. We've had a couple of publications about it, understanding self-agency, looking at the literature, seeing what's already been written and how we can make the most of it. And then we applied for a competition, and we won the competition, which gave us a few £1,000s to do some research. So we're just in the middle of getting ethical approval for that. And that is going to be exploring self-agency a bit more. So we're going to be interviewing people who've gone through types of therapy to find out what happened. Where was their self-agency at the beginning? Did it change? How did it change? What were the consequences for their lives afterwards? And how can we understand it? And then we're also doing a survey of staff from different types of psychotherapy to see, how do you see self-agency? What do you call it? How do you promote it? How do you make the most of it? So then we'll understand it a bit more, and then we can move on. We can think, we probably want to find a way of measuring it, come up with some sort of questionnaire or measure. Then we want to think about interventions, ways that we can optimize it. And that's one I feel really passionately about. It's a real interest of mine. It's something I've seen with the people I've worked with. And when I've seen them figure that out and go off and live the lives that they want to live, it's so rewarding. It's the most rewarding bit of my job. So anything I can help them with that, I'm going to put some effort into.
I believe that could be also adapted to other difficulties, not
Yes,
necessarily complex emotional needs.
I totally agree with you. I think it's central in complex emotional needs, but it's very important for most things.
Mm.
And in mental health, it's actually quite unusual that you just take a medication and all your problems go away. That you do have to find something in yourself. But wider still in health, you also have to make changes, don't you, as
Yes.
into how you live. Someone else can't do it all for you, and certainly to make things sustainable. So yeah, I totally agree.
Yes, and I
You have
think
to want to help yourself also
Yes.
yeah, for
But
changes to
that's not
happen.
easy, is it?
No, absolutely
It's
not.
not.
Absolutely not.
and I'm thinking also of patients perhaps that have difficulties in life or had, for example, cancer treatment,
Yeah.
and self-agency can be also
Yeah.
adapted to this
Yes, I think
type of
yeah,
situation.
probably all the areas I can think of. So we'll start the work, and then yeah, I'd love to take it further, or for other people to join in or get inspired.
Yes, there's a lot of possibilities with this.
I hope so.
Um, so as you know, we are a trust that combine acute and mental health. And that's not very usual,
Yes.
as far as I know. And from your perspective, how this is an advantage or disadvantage, how can you can see that, how can this can help each other's, the acute and the mental health,
Yes.
be under one roof?
Well, that's a great question. I don't have a straight answer for it, but you're right. I think it's a real opportunity, and I think we're probably not making the most yet of the opportunities.
Mm.
But I found whenever I've done things like this, or occasionally been in our news, people have sort of come out the woodwork in other parts of the trust and got in touch, and I've really enjoyed that. And I've met some amazing people doing exceptional work around. So I've met actually people in the cancer services. There was a whole team of counsellors and psychotherapists there. There's a psychologist on the ICU who I'm working with as well to do some research there. So mental health sort of infuses, I think, a lot of the other parts of the trust. Again, in complex emotional needs, this group of patients comes up around in other parts of the trust, particularly in ED and A&E, in the medical and surgical wards, and in primary care. And so we're sort of trying to make those links and make use of being in the same organisation for how we can help each other. And the big research project I talked about at the beginning, one of the things they've noticed is how fragmented things can be if you're not careful. And how amazing is it that we're all together in the same organisation, so there's an opportunity to make the links between things. And that's where we need to put in, I think, a bit more effort, but a bit more perspective, I think. Take the wider view and see what we can learn from each other.
Yeah.
Yeah, I think that's great. And I think, like you were saying before, one of the biggest misconceptions about something is just getting started or knowing where
Mm,
to look, where the resources are.
yeah.
And obviously, as you mentioned, one of the big things is the daunting of just actually starting a research project
Yeah.
or knowing who to talk to.
Yeah.
But are there any other misconceptions about mental health that you want to clear up for our listeners?
Oh gosh, that's a big one. Oh well, there's lots actually. Oh dear, where shall I start? Okay, well, I must start with complex emotional needs, I suppose, because as I said, this is a group of people who have lots of difficulties. And when they're in a crisis, it's a really terrible situation for them. And really, in services, in mental health services, but also in the more general health services, that's when we can see people. So they're in a crisis, everything's gone a bit wrong, and there's no easy answers usually. So pretty much everyone's having a hard time. The patients are, the clinicians are around them, and it's really not easy. And people can kind of easily get into a way of losing compassion for people if you only see people in a crisis. If you never know what happens later or find out about the rest of their their interesting and productive lives, then that's all you see. Then this group can get quite stigmatized. And I've seen that everywhere I've ever worked across the country. So we're looking at that bit by bit, just helping to understand people, and that how they're presenting is usually an expression of distress. It's not that they're trying to do something deliberately to annoy anyone. So that's the main thing, that stigma, I think. And the other thing is probably about hope, actually. So yeah, things can improve, things can get better. That's definitely true in complex emotional needs, but something that people don't think is true, but it is, and I've seen it, but probably across all of mental health, actually. And we need to, I think it's our job to keep that hope going, keep the positivity alive, and yeah, create the space where people can meet us and progress with their lives.
Perfect. Thank you.
Thank you. Another thing perhaps that I've seen regularly talked about is diagnostic overshadowing.
Oh, yes.
So as perhaps a misconception of the fear of diagnostic overshadowing. So diagnostic overshadowing is someone presented with mental health difficulty,
Yeah.
presented with acute, comes to an emergency, for example, comes to an emergency department with acute difficulty, and the overshadowing is that it's attributed to the mental health difficulty.
Yeah.
And then because of not understanding the mental health difficulty, the misconception is the diagnostic is put on the mental health
Yeah.
difficulty, and therefore the acute difficulty is not addressed. So that could be also it's also the where being under one roof
Yeah.
could benefit from both, from mental health and acute, to better understanding
Yeah.
of
I hope so.
what is it.
It's very interesting, isn't it? Because mental health is the thing, and learning disability is the other. But in our service group, it's mental health and learning disability, and that's another place with known diagnostic overshadowing. That if someone with a learning disability experiences anything, it can be, if you're not careful, put down to the learning disability. But mental health too, and I do a lot of work with people with lived experience of mental health problems, and I did so many stories. I had a pain or some physical symptom, went to my GP and they said, oh, it's probably a mental health. So people can feel a bit fobbed off, and I think women can that can happen to women, and we've heard a lot about that, haven't we? Women's health issues not being taken seriously and not being treated perhaps in the same way. So you can have a bit of intersectionality, I think, bit of double whammy with women with mental health problems, with learning disability as well, perhaps. You can imagine. So I think we can help each other in that, with awareness, with training, and well, just communication, really, just talking to each other. We can perhaps figure it out, rather than making too many assumptions. So much we don't know in medicine. That's what I learned at medical school. There's loads that we don't know. They teach us the bits that we do, because then we can do something about it. But there's a whole load of stuff out there that we don't understand, and we may understand in time, or we may never. But we can't just dismiss the things that we don't understand. Fine, we may not know what to do about it yet, but it's sort of real stuff, isn't it? And when people are suffering, so it's not all in your head, which is sometimes what we hear in mental health. And those sorts of symptoms need to be taken seriously. There might not be a physical treatment, but we can help people, I think, to manage what's going on for them, validate their experiences without dismissing them. And I think, that would go a long way to helping a lot of people, wouldn't it?
But yeah, so it's been super interesting to talk to you. It's definitely an area that you kind of think about research, but it's really interesting to hear the specifics of like the mental health research
Oh, good.
and the projects that are sort of happening. And I think it's always lovely to get to talk to people who are in that areas around the trust, because it's not something that your everyday clinician might know that it's happening, or know that the support's available.
Right.
So it's lovely to sort of have that and then be able to share that with our listeners.
Good, thank you. Very well. Anytime.
So on that note for mental health, I'm going to talk about a resource called PsycInfo, which is a comprehensive database that provides a wide range of literature across psychology, social behavior, and health sciences, giving you access to valuable resources for evidence-based practice, research, or even just your professional development. So whether you're exploring mental health topics, behavioral research, or the social factors that can influence health, PsycInfo offers high quality, peer reviewed content to support your work. You can access PsycInfo for free using an Open Athens account, making it really quick and easy to sort of get started. So please make use of the resource that is available to you, and I will pop any links below. I know Letitia's very happy with with PsycInfo.
I will call it the bread and butter for everything I do for mental health. I say I don't do it without taking for it.
Yeah. So talking obviously about research, our research spotlight today is going to be hosted by Letitia. So I'll pass over to you.
Yes, thank you. And actually, it really links what we were talking about, Adrian, because the article it came out last week. I think I was aware of it last week. So the title is Psychological Practitioners Perceive Barriers and Solution for Facilitating Access to Mental Health Services for Adults with Intellectual Disabilities. So exactly what we were talking about. So the article was published and written and co-authors from people in the trust in mental health. So the authors are Joanna Doherty. So sorry if I made any mistake in saying their names. Maisie Knight Davis and Freya Gomes. So I believe Maisie and Freya are in the trust.
I think they all are or have been.
Or have been,
Yes.
yeah. So, and clinical psychologist, and trainee, I think was. So anyway, so the article is looking at so we know that, as we said, adults with intellectual disability do not always get the help they need. And we were talking about diagnostic overshadowing, so that's very much like that. So this article is looking at the barriers and solution to offering and implementing reasonable adjustment through the exploration of staff view. So is looking at what the staff thinks about the barriers and the challenge and the solution for this population to access health services. So what they did is they did focus group, and they use staff from adult mental health services, and that also include intellectual disability service. And when they did these focus group, there's 4 general themes that came out of it. So the first theme is around service barriers for reasonable adjustment. So mainly around inadequate provision in service, such as unrealistic targets. So that was one big thing they said, and the need for clearer pathways to understand all of this. And one of the other thing was the need for adequate training. We were talking about it as well, and better understanding of intellectual disability and what it means to be someone with intellectual disabilities. So we talked about it as well, and the need for joint working. So between services, with, for example, sufficient handovers, informal consultation, co-production. Again, we talked about this. And the last thing was around what does reasonable adjustment means in practical term. What is it? So from these 4 themes, then we had change IDs that came out of it. So I'm just going to give few examples of change IDs. And for example, was breaking down silo working. So what we were saying, encouraging discussion around reasonable adjustment, say structuring stronger training support, presentation, resource package, maybe have champions, creating handover meetings. So that was the few of ideas, which I think it was really interesting to to see this more articles like this coming out, and actually really based on applied research. So
Sounds like a very interesting article.
yes.
I will pop the link below if anyone does want to read the
Yes, so
full article.
to access to it, the Open at an account is there, and the trust will give access to it
Exactly.
through our resources.
So now on to my favourite section, which is our reading corner. So as I mentioned before, we have some very exciting news, which is that we've received funding from Love Musgrove. So thank you very much to Love Musgrove. We've been able to purchase 69 brand new leisure reading books by international authors. So all of these books are award winning. Some of them are like the Book Talker Awards. Or finalists, all chosen to support staff well-being. The titles offer a fantastic opportunity for staff to relax. They can come and borrow a book. Half the collection will be held at Musgrove, half the collection will be held at Yeovil, but we can also, as with all our books, send them to community sites. They will be available to borrow the week commencing Tuesday the 26th of May, because I'm still cataloguing some of them, which is also when we're going to launch our Around the World Reading Challenge. So this challenge will invite you to read 8 books by international authors, with each author being of a different country of origin, which is going to be a great way for people to broaden their horizons and discover new voices and perspectives. You can borrow our books, you can borrow books from the public library, but this challenge will run from the end of May through to December. And there will be some prizes at the end. So keep an eye out, join the challenge, and as I've said before, discover your next read. The link will be in the description below. But that brings us to the end of the podcast. So thank you very much for coming on, Adrian. It's been absolutely lovely to have you on.
Very welcome. Thank you. I've enjoyed it. What a
And
nice
it's been
chat.
lovely to have you on as well,
Thank
Letitia.
you. It was lovely to be there and lovely to have you, Adrian.
Thank you. Letitia and I work a lot together. We work well together, I think, don't we?
You do. And that comes across. It's been a very good episode. So on that note, thank you for listening, and we will see you for episode 9 in June.